Good afternoon. At the outset, I pay my regards and homage to Professor Arun Kumar Mujumdar, whom I recall that he has been present in every meeting, and he always was a very encouraging person, and he used to ask very critical questions. So I pay my deep respect and homage to him. And I thank Indian College of Physicians Western Branch for organizing a meeting made possible after 2 years. So what I will try to do, we'll start with a case and we'll be discussing the morphology of different skin lesions. How do you approach to a patient? I'll be showing some patients and finally some concluding remarks. My first patient, a 30-year-old male whom we saw in June this year, unmarried private tutor from North Kolkata who didn't have any past significant illness, admitted in another facility with a history of daily rise of temperature, headache, which was excruciating when he had a height of temperature and body weight. He didn't complain of any sore throat, cough, urinary bile complaints, or joint pains. And he noted a rash which appeared on the day 3 of his illness. This is the rash. You can see initially it was like this, and later it became like this. Testing was done in that facility. COVID negative, complete blood count only show a low platelet count of 88,000. Routine urine, LFT, urea creatinine normal. Malaria, dengue, typhoid, scrub typhus, leptospira, ANA, HIV all are negative. Urine and blood culture didn't show anything. ECG, chest X-ray, ultrasonography, abdomen, CT scan of the brain didn't reveal anything. He was empirically treated with injection ceftriaxone, doxycycline later was added, but he didn't respond, so he was referred to us. We found his conjunctiva were congested. He had no oral lesions, few discrete cervical lymph nodes, chest and abdominal examination normal, neurological examination only possible. He had a doubtful neck stiffness. We referred to eye department and they commented a possible presence of papilledema. We did all the repeat tests. Only the platelet count was low at 78,000. CRP was very high, 124. Our normal is 5 and ferritin was 1800. Echocardiography was normal. We did a CSF. It was clear with a little raised pressure. There are 50 cells, mostly lymphocytes. Protein was a little raised, 78. Glucose was 45 with a CBG of 90. Gram stain culture, no result. Fungal stain, CBNAT, negative. And we also sent JE and HSV-PCR, all were negative. So this was in our background. With this background, I start my talk for today. So when we see a patient, all what we do, we see the morphology of lesion. We know the macules are flat lesions with a less than 10 millimeter in diameter, and patch is a larger macule. A papule or elevated lesion which are less than 10 millimeter, and it can be felt or palpated. Plaques are palpable lesions which are more than 10 millimeter diameter. They can be depressed or elevated. They may be flat topped or rounded. Nodules are firm papules or lesions which extend into dermis or subcutaneous tissue. Vesicles are small, clear blisters with less than 10 millimeter diameter. And when they contain pus, we tell them as pustules. Bulla, the clear fluid-filled blisters with the more than 10 millimeter in diameter. We can have urticaria, which is characterized by elevated lesions caused by localized edema. Scales are hipped up accumulations of horn epithelium, and crust consists of dried sebum, blood, or pus. Pitaceae, we know, are non-blanchable punctate foci of hemorrhage, and when they are a larger area of hemorrhage, you call them a purpura, which can be palpable. And larger areas of purpura may be called ecchymosis, or sometimes we call them as bruises. So as all of us know, we go with the usual history-taking methods: age, season, geographical setting, how is the pattern of the fever, which is very important, nature, duration, and chronology of the rash, because rash is an issue, and also if there is a previous history of rash. We also can ask about any joint involvement, any recent medications. This is very, very important because all of us know that there have been issues when Ayurvedic drugs have caused rashes, homeopathic drugs have caused rashes. History of immunizations, history of exposure to sexually transmitted infections, risk factors for HIV like unprotected casual sex, homosexual orientation, intravenous drug users, immunological status, whether there is any malignancy, chemotherapy, corticosteroids, or asplenia, any valvular heart disease. Is there any history of exposure to febrile or ill patients in the recent past? Exposure to wild or rural habitats or wild animals? Any history of prior illness, using a drug or antibiotic allergies? Travel history is very, very important. Though COVID has restricted our travel, but still people are traveling. I myself love traveling. Pets, Now coming to the physical examination, all of you know, just for a brief recapitulation, vitals: is the patient stable? Is the patient acutely ill? Is the patient chronically ill? Is the patient toxic? Lymphadenopathy, very important. There's a conjunctival, mucosal or genital lesions, any arthritis or arthralgia, any findings in the chest, is there any hepatosplenomegaly, and are there any neurological dysfunctions or neck rigidity? Now coming to the features of rash, all of us know, just a recapitulation. What is the type of the rash? Is it discrete or uniform? Is there any discoformation? How is the configuration of the individual lesions? What are the arrangement of the lesions? What is the distribution pattern? Very, very important. Are they present on the export part or covered areas? Are they centripetal or centrifugal? Now, just all of us know that there are classical morphological lesions. Like when you think of a maculopapular lesions, we know measles, rubella, HIV seroconversion are some of the representative illnesses which have this type of rashes. Erythematous rashes you can see in early stages of Stevens-Johnson syndrome. SLE is a very important in connective tissue disorders and some other conditions. Vesicular rash, we know varicella, herpes simplex, and other few others can cause a vesicular rash. Bullous rash we see in group S streptococcal erysipelas with necrotizing fasciitis or staphylococcal or streptococcal cellulitis. Vesiculobullous rash will show you SS, Stevens-Johnson syndrome, toxic epidermal necrolysis or drugs. Petechial rashes classically in meningococcus, rickettsia, and atypical measles and viral hemorrhagic fevers. Eschar we know we can see in rickettsial infections and annular lesions. I remember Dr. Shantoshil Pine's student showing us a recent erythema chronicus migrans case. And when you get a pruritus, you think of varicella and articular rash with the commonly pruritic, and there will be variable pruritus in drug eruptions and erythema multiforme. And usually HIV seroconversion, roseola, rubella, they don't give a pruritus. Palms and sole involvement. Well, common in rubella, erythema multiforme, Stevens-Johnson syndrome, toxic epidermal necrolysis, Kawasaki's disease, and they're absent in certain other varicella and erythema infectosum. So I'll show some photographs. All of you know these patients, but just to remind, you can see the deep red appearance, fever, body ache, and joint pain, and red rash. Diffuse erythematous rash, you can see that we can compare with the color of the vermilion above. You can see a blister in the ear of another boy with similar illness. Swollen joints of a person with similar illness, subconjunctival hemorrhage. And following this disease, you can see the facial pigmentation. You can know this is a post-chikungunya. So chikungunya, we have been seeing outbreaks every year. This is the time of the year when we see chikungunya cases. And this lady presented with fever, followed by rash and polyarthralgia, post-chikungunya arthritis. You see in around 5% of the patients who suffer from that. Classical dengue rash, you can see the blanching on pressure of the fingers. Another white person, we can show in the classical dengue rash. And this is a very classical 6-7 day rash, 5-6-7 day rash. When you see white islands in sea of red, you know that this is dengue. You can see a hemorrhage, gum bleeding in a child. You can see subconjunctival hemorrhage and bilateral pleural effusion, dengue hemorrhagic fever, ascites, bilateral pleural effusion, as well as ascites, another patient with complication, dengue hemorrhagic fever. Recently, this is a news. Kanpur has reported Zika cases, 89 cases recently. Very easy. Do we know we have been seeing Zika? This has been seen in Rajasthan first, then we have started seeing in these various places. This year, we have seen this Kedal, Maharashtra, and Kanpur is the addition. We must be aware about Zika. So we know it has been changing and increasing in the distribution from 2007. It has caused large outbreaks. In 2013, we became concerned because it has caused Guillain-Barré syndrome and also microcephaly. That is the area of concern. Though they are saying that the Indian variant does not yet cause this thing, but we have to be concerned. Recently, there's a history of story. I should not say story. There's a story of UP. Some of the UP women have been made to undergo abortion because they have been found to be suffering from Zika. I don't know whether it's true or not. It's a story still yet, but we need to be concerned about Zika. Usually, it's a minor illness with conjunctivitis, mild fever, headache, and exanthematous rash. There is joint pain. The symptoms normally last for 2 to 7 days, and 1 out of 4 people they get infection. But please remember, we have to be concerned about Zika, what is going to happen in future. Some other illnesses. Rubeola. This lady came with fever, rash, and cervical lymphadenopathy. Rubeola, you must understand and diagnose. With skin rash, drug rash, evidence rash in this lady. Young boy with drug rash due to Ayurvedic medicine. He was given Ayurvedic medicine and he came to us with this type of rash. And very serious, you can see Stevens-Johnson syndrome, very blistering rashes. This lady came to us with fever, joint pain, and classical rash. All of us know this is SLE. We thought it is SLE, but this is a story of 2013, I remember. And we just, because we are having chikungunya outbreak, we sent the blood for chikungunya IgM, which is positive. So chikungunya resembling SLE, be aware of this. Fever, jaundice, conjunctival congestion, pulmonary hemorrhage. You can see the CT scan. And after the treatment, this boy recovered. He was leptospirosis, severe pulmonary leptospirosis with pulmonary hemorrhage. So this can happen. Erythema nodosum, you can see on the legs with very many conditions associated. I'm not going to name them. This is polymorphic rash of chickenpox, all of us know. This lady came with fever, jaundice, hemorrhagic spots. You can see the legs, and she was in our ITU, and it was vivax malaria. So we can get complicated vivax malaria. It's not that only falciparum gets a complication, but you can get complicated vivax malaria with all the manifestations. This, all of you know, this case I saw in 2006, but we have been seeing this case regularly, fever, rash, and eschar. Another case, you can see the eschar and lymphadenopathy. Another case, you can see the eschar and fever, temperature. Another case with fever, rash, pulmonary involvement, and the eschar. So, scrap typhus, all of us know by this time, is very easily treatable by doxycycline, but we not need to recognize that. Another interesting cases. This person came to me in 2012, as if I recall correctly, young middle-aged person came to me with fever and rash and lymphadenopathy. I thought it's dengue. I sent test for dengue. It was negative. I sent a blood for liver function test. If you can see this, the SGOT was 402 and the SGPT was 255. So this is classically happens in dengue. I thought they are missing the test. So I sent to another good lab. Dengue was again negative. So I was scratching my head. What is happening? Then somehow I sent this test. You can see the HIV P24 antigen was positive, antibody didn't appear. So, and the Western blot was also negative. So this was, and we did a viral load. This HIV viral load was more than 21 lakhs. So this was HIV seroconversion syndrome. I have never seen this in earlier. So this is HIV seroconversion syndrome. Normally we fail to recognize this because we are dark skinned. But if you feel a fever with rash, lymph nodes, you are excluding dengue, please keep that, take a history and you might get a reward at some point of time. Another patient, a class 12 year student, class 12 student from Bednipur without any significant past illness, was unwell from 30th of May. Initially low grade fever, then picked, was vomiting. He felt very unwell and was noted a rash and was admitted to a facility in Bednipur on 6th of June this year. As he was deteriorating, he was transferred to a private hospital in Kolkata, not in my hospital, but where I go as a visiting consultant. He was needing pressure support or noradrenaline support. You can see the boy, you can see the rash, you can see the periorbital lesions, you can see the cracks on the lips. This is a trunk rash. This is a scrotum. There are scaly lesions on the scrotum and there are lesions on the palms. And what are the other investigations? Total count was 33,000 with a neutrophil of 92. CRP was 140, ProQual was sky high 22, ESR 80. Malaria, dengue, leptospirosis, crab, negative blood culture, no growth. Pro-BNP was very high, 4,000, more than 4,000. Ferritin was 2,000, D-dimer was 2,000. Echocardiography showed features of myocarditis, so the diagnosis was obvious. We sent a blood for SARS-CoV-2 antibody and it was positive. So it is a multisystem inflammatory syndrome in a child. Now I come back to my first case. What we can see, we have also multisystem inflammatory syndrome in adults. What does it signify? Who is the patient? A patient more than 21 years who has been hospitalized for more than 24 hours or in an illness which can result in death, who has some clinical criteria and some laboratory criteria. And he should not have an alternate diagnosis to explain that thing. What are the clinical criteria? Subjective fever or documented fever for more than 24 hours before hospitalization or within the first 3 days of hospitalization, and at least 3 clinical criteria within the first 3 days, and of these 3 clinical criteria, at least one has to be primary clinical criteria. What are they? Severe cardiac illness, which can include myocarditis, pericarditis, coronary artery dilatation, aneurysm, new onset right or left ventricular dysfunction, second or third degree heavy block, ventricular tachycardia, rash, and non-purulent conjunctivitis. My first patient had conjunctivitis and he had rash. What are the secondary clinical criteria? There can be new onset neurological signs and symptoms, which can be encephalopathy in a patient without prior cognitive impairment, Seizures, meningeal signs of peripheral neuropathy, including GBC and Guillain-Barré syndrome. My patient had meningeal symptoms. Shock or hypotension, which is not attributable to medical causes. Abnormal abdominal pain, vomiting, and diarrhea, and thrombocytopenia, platelet count less than 1,50,000. My first patient had persistently low platelet count. So, and what are the laboratory evidences? Elevated levels of the CRP, ferritin, IL-6, ESR, procalcitonin. My patient had very high CRP and ferritin, and a positive SARS-CoV-2 antigen antibody, either RT-PCR test or serology or antigen detection. My patient has positive SARS-CoV-2 antibody. When I inquired with that person, he told that his elder brother's wife suffered from fever, cough. They didn't test for COVID. But possibly he was infected at that time also. He didn't have any symptoms. And now this has resulted in a multi-system inflammatory syndrome. So this is ICD code. Few patients with prolonged fever and rash, interesting preference. This is a male SLE. You don't see this very often. This is an interesting patient who presented with fever and recurrent nodular eruption. You can see there are nodular eruptions. And when smear was taken from that, it was positive for acid plus bacillus. So this was erythema nodosum leprosum. Please remember, you physicians can get patients with lymphadenopathy, nodular eruptions, fever. It can be component of ENL, and of course, leprosy is still there in our country. This patient presented with ulcers, fever, and adrenals were enlarged. We could get histoplasma. All of you know this. So histoplasma, disseminated histoplasmosis. This lady came with ulcers on both sides of the cheek. You can see ulcers on both sides of the cheek, persistent. We did a HIV test. She was positive. She got it from a blood transfusion. Now, because it can be due to herpes simplex, so we treated her for acyclovir, and she also had chest X-ray showing this. So she had lung involvement also. Acyclovir improved the left-sided ulcer, but did not improve the right-sided ulcer. So we took a biopsy from the right-sided ulcer, and we found histoplasma. We treated her for histoplasmosis. Now the right-sided ulcer healed, and the chest also clean. So it can be a presentation of histoplasmosis. So all of us know that the management has to be mainly supportive, and the causes for which we have a treatment, we need to give symptomatic supportive treatment. Some of the cases need to be notified. So please notify the appropriate authority, because unless you notify the state, our health system doesn't know that this is happening. This is a very important part of our work. And preventive actions in the form of vector control, environmental management, and prophylaxis for diseases which we do have. So I'll conclude by saying that feverish rash is a very, very common problem. You can have infections, autoimmune diseases, hematological conditions, as well as drugs which can cause this type of feverish rash. Take a thorough history, as your teachers have been telling, my teachers have been telling, I have been telling my students. Please tell your students also, because history, thorough examination, and minimum test, because our patients don't have a lot of money in the pocket. So please think about the patient's pocket also. Keep the local epidemiology in your mind. And if you have a doubt, you can please consult a dermatologist. And thank you very much for your kind attention.